Thank you, Gary, for introducing me. As Gary said, I am at the Norwegian University of Science and Technology, and I'm a member of two partners of GUIDE. This is TESS, the Trondheim Early Secure Study, and CHAIN, which is a center of which aims to address global health inequalities research at the Department of Sociology. And Tari Aikamo, who leads this center, was not able to be here today. So I would like to structure my presentation to briefly present both TESS and CHAIN and the recurring data needs. And I also would like to stress why we need new data collection longitudinal such as GUIDE aims to do. I would like to start framing the work we are all doing or involved in this theoretical model of social determinants of health and well-being. This is a rather complex model, but I just want you to think about these three most important levels of inquiry when we aim to address the social determinants of health. On the left-hand side, it's the socioeconomic and political context. Then it's the social stratification within each society and the individual behavioral, material, psychosocial, and biological factors which determine health and well-being. So importantly, the TESS, the Trondheim Early Secure Study, which is a birth cohort, which addresses children's mental health development. In TESS, we address these individual determinants of health and well-being within the family and socioeconomic position, where in CHAIN, CHAIN focuses on the social inequalities in health within different sociopolitical contexts. Here about the TESS study. So as I have said, this is a longitudinal study of mental health, psychosocial development, and health behavior. It's from preschool to young adulthood. It's conducted in Trondheim in Middle Norway. And this is a representative community study of two cohorts of children which were born in Trondheim in 2003 and 2004. And the first data collection consisted of around 1,000 4-year-olds. We have also enough power because the children with emotional and behavior problems were oversampled at the baseline. And these children were then interviewed together with their parents every second year until they were 18 years old. It was the 8th data collection, which was finished last summer, with comparatively relatively low attrition for such a longitudinal study. And the new data collection will start this year with young adults around 20 years old. So the goal of the study is to determine the prevalence and course of common mental disorders and health behavior and the etiological factors of such outcomes. In addition to this, TESS also describes a wide range of children's and adolescents' typical developments, such as social and academic competence, social relationships, physical activity, eating and sleep, and also gaming and social media use. Here in TESS, these domains that we investigate can be summarized in terms of biological, social, and psychological domains. And importantly, we also focus on the important part of children's development. It's the children's family, school, and peer relations. The data collection is rather comprehensive, so the children are assessed during 4 hours at the university through means of a semi-psychiatric psychiatric interviews, where both children and their parents participate. In addition, we also observe the children and the parents in the lab. The children are tested, and we objectively assess their BMI, physical activity, and sleep. And we also collect information from school and preschool teachers. And the study can be also linked to Norwegian registry data. So here I would like to draw on some experience with the TESS study and how can how this can underscore the importance of a new guide study. We all know that children's development is multi-determined, and it also happens with the reciprocal interaction with child's environment. So we need to assess the development longitudinally over time. And here is an example of a study where we assess the reciprocal interactions between child problem behavior and conflicted relationship with their teacher in preschool and school from the age from 4 to 12 years old. And due to the longitudinal design, we were able to assess the within person, the intra-individual processes of children's development. And that's really a big asset in comparison to traditional structural equations modeling, where we can really look what happens on the intra-individual level. But we were then interested, is it a general finding, or can we also more generalize to other populations and contexts? So we compared our findings with USA NICHD study, but we faced several challenges. And one of these was the measurements. Even though both studies used the same measurements, they were not identical. There were different lengths or versions of the measurements. So we needed to make quite some efforts to harmonize the data. And we faced similar challenges in terms of other predictors and covariates. And there were also some other challenges related to the age period, because although the children were collected or assessed at similar ages, the children were not consistently assessed throughout the follow-up, so there was different timing and different periods when the children were assessed. So if we then find some differences between the two countries, it's very difficult to ascertain what can the different results be a result of. So therefore, we need a study which is already harmonized from the beginning of and uses standardized measures. I know that other longitudinal studies, which Gary earlier mentioned, they face similar challenges because the measurements are not directly comparable. Is that in addition to collecting individual data across lifetime, we also need to collect data in different cohorts to better understand cohort effects. So in a recent TESS study, we found no reciprocal effects between adolescent social media use and symptoms of anxiety and depression. And this finding can be illustrated on the top right corner. However, at the cohort level, more use of social media and screen may also be linked to worse mental health, for example, through less physical contact as time goes, more social isolation, which might then lead to worse mental health outcomes. However, we might not observe the same patterns at the individual level, because we can imagine that those who use more social media might also have more physical contact with peers and thereby not worse mental health. So we need to disentangle the cohort and the individual effects of these associations. So as for the data needs, we all know that there is a replication crisis in psychological research, but also in medicine and medicine and social science, where about 50% of studies are not being replicated. So remedy is to use standardized, harmonized measures with enough large and representative samples. And we also need to pay attention to the context. We all know that children's development is often happens with reciprocal exchanges with different environments and different domains of the environment. So we need longitudinal data to better understand the impact of the different predictors. And we also need data that can ascertain changes between generations. And to disentangle the reciprocal effects at the within person or the intra-individual change, we also need to assess data at least at 3 time points. And such longitudinal measurements and findings can better help us to understand the direction of the effects, the size of the effects, and bring us closer to understanding causality when observing longitudinal change. Representative samples is also a large challenge. I've recently talked to my colleagues in Norway who work with the Gender and Generation program study, and it's a large challenge to have enough power and large enough sample, including the minorities, immigrants, and the vulnerable populations. This is also a challenge for the TESS study and for the mother and child cohort, birth cohort in Norway. So as society develops rapidly, children develop as well, we need a new cohort. Currently, there is no child birth cohort in Norway because there has been a massive increase in social media and screen use. And to assess how these impact the development, we really need to get data on this. And also, as the world is changing with wars and the recent pandemic, if we have these data at hand, we can better understand how different contexts impact on children's development. For example, how different school closures during the COVID pandemic could have impacted on children outcomes at the different countries. So we need a new data cohort infrastructure which could be comparable between countries, where we'll be using the same cohort age, period, and spacing of data collection. Next, I would like to present a chain, which is a Center for Global Health Inequalities, which is led by Tarja Aikemo at the Department of Sociology. And I would like to draw on experiences in chain in collecting, harmonizing, and analyzing comparative data on health and well-being across countries. Chain's aim is to monitor, explain, and reduce social inequalities in health, and Chain's vision is to promote health equity through research excellence. In Chain, we believe that all people have the same right to good health, and it's a matter of social justice. So Chain works to create a global transformation of actionable health research by bringing together scholars and international organizations such as UNICEF, WHO, with a common to better determine how we can target water resources to reduce health inequalities. We see that there's been a large decrease in child mortality in the recent 20 years compared to the period before, but we still observe a pattern of social inequalities where children with low educated mothers or with mothers with no education experience high levels of child mortality. So to briefly sum up all of the Chain activities and the pillars, Chain aims to monitor international variation in health inequalities between and within countries. Chain also aims to explain health inequalities within countries. And finally, Chain aims to identify policies and interventions that could reduce health inequalities. This can be done by, for example, reviewing past interventions through systematic reviews and evaluation studies. Chain cooperates with international organizations, public and private sector. And what is common for all these three pillars is that it's a large geographical coverage, both on the global north and global south, in terms of the data which is being collected. And Chain also promotes to focus already on childhood and in a life course perspective. And finally, also to focus on intersectionality. Here are a few examples of what Chain undertakes within each of these pillars. It also highlights some of the partners of Chain, most notably UNICEF, WHO, and the European Commission. For example, within the monitoring pillar, chain works together with the global burden of disease study, or the GBD study, which is based at the University of Washington. And chain has also developed 2 rotating models on the social determinants of health as part of the European Social Survey. Chain also hosts the largest comparative data source on education and score-specific mortality in Europe. And this data from monitoring then tap into work on explaining the inequalities. For example, chain leads the work of the WHO Technical Advisory Group, which works on the importance of social conditions for COVID mortality. And an example of the reducing pillar that study wanted me to mention is the microsimulation, which proved to be a flexible tool to evaluate policies and their impact on health inequalities. This is a recent paper from last week. Chain also cooperates with Innocenti. Indeed, Chain visited Innocenti in May last year. And this picture is from a network meeting hosted by Walter Rees here. And one example of the cooperation is the Innocenti's report card series, which Chain has been involved in as well. So in addition to describing and explaining the inequalities, for example, in mortality in Norway, such as in this example of the paper, Chain also works and underscores the importance of cross-national studies, which are important. And here we can better understand social inequalities in women's health as they manifest differently in different European welfare regimes. And guide with new data on children development could really add to better understand how these inequalities already form in early life. This is another theoretical understanding of the complex interplay of socioeconomic and contextual factors in health. And in this model, which is developed together with TESS, Chain, and Promenta in Oslo, there are 2 guiding principles that we need to look at the developmental and interactionist perspective. So tracking the development from birth to adulthood across generations and in family and societies. And second, health inequalities are also shaped through complex interplay of factors at different levels. As we see, there are 3 major key challenges in health inequality research. First is this question, everlasting question of the relative importance of social causation versus selection. We also need to clarify the biological and psychosocial pathways through which inequalities in health and well-being develop. And also we need to identify contextual and individual moderating factors. In Norway, there's been already a few years ago, it has been addressed the need for interdisciplinary, longitudinal, and long-term collaboration between different research environments. And Chain has really taken this work forward, for example, through a cooperation with the Institute for Health Metrics and Evaluation, which runs the GBD study, to incorporate the social determinants in the study and also to bring better understanding of the interplay of social factors and health. This is a picture just illustrating the GBD study, which is the largest collaboration in science. And here, this covers a lot of countries, but still the GBD, even though it covers all age groups, the data between the ages 5 and 18 are often lacking. So this is just an information about the GBD, which quantifies the magnitude of health loss globally. And this is a recent publication which has done a systematic review and meta-analysis of the association between parental education and child mortality. In addition to these objective measures of health, CHAIN has also focused on subjective measures of health and well-being. And the European Social Survey is a result of such focus. And in ESS, which is a cross-sectional survey, which is run every second year, the teams are invited to make their own rotating modules. So CHAIN has been involved in work on designing a health module in 2014 and in 2000, which will be accessible in 2024. This is just an illustration of the health module, where all the behavioral or the most important behavior material, occupational and psychosocial determinants will be represented. And this module has also many questions on chronic conditions, including, for example, depression index. CHAIN plans to publish a special issue on this rotating model. So if you are interested in collaboration, please reach out to CHAIN. And if you want to collaborate, here you see a map of clusters of ESS publications, and the blue cluster represents health studies. So you see that health is a large part of this survey. Yes, this is just the designs today, which the CHAIN team has worked together with Rory Fitzgerald, who is also here. And here is just you see the faces behind the question design team at CHAIN. And this is a meeting at the European Commission, where CHAIN also has a good connection to. And the European Commission is really interested in the work that CHAIN is undertaking. So just to sum up, we see, based on our work in TESS and CHAIN, that there are still serious limitations in current surveys that prevent us from examining trends in health inequalities and their determinants across contexts. So we really need a big-scale longitudinal cross-national study, which would focus on such determinants. And I would like to underscore the need for vulnerable populations like the immigrants, people who are not speaking the main language in the country, and children especially. So the last slide or next slide, last slide is why we need CAR, because we really need harmonized and longitudinal data to describe children's and youth development. And importantly, this data would enable us to understand the processes at the individual within person level in their interaction, the reciprocal interactions with the environment across life course. And second, we need cross-nationally comparable longitudinal data to understand the differences across lifetime in different sociopolitical contexts and across generations. And such data and the results of this would then inform better the social policies and how they impact on differences in children's well-being and health. So this is a contact information, and if you are interested to collaborate with CHAIN, you can also follow us on social media or just reach to us. Thank you.